Hello, everybody. Welcome to a new episode of the Dissenter. I'm your host, Ricardo Lopes, and today I'm joined for a second time by Dr. Joel Paris. He is professor and chair of the Department of Psychiatry at McGill University and research associate in the Department of Psychiatry at Sir Mortimer B. Jewish General Hospital. So, Dr. Paris, welcome to the show. It's a pleasure to have you on.
It's great to be back. Just to tell your listeners, I'm no longer chair of my department because of emeritus.
Okay. So sorry about the mistake then. Let's start. Last time we talked a lot about psychoanalysis and its impact on psychiatry and so on. So today we're going to talk about a bunch of different topics. Let's start with, could you tell us about the past history of psychiatric fads and perhaps what are the sorts of lessons we can draw from it for the present?
Well, when we don't know enough, fads step in to fill the gap. And that's happened a lot in psychiatry. I mean, some of the more famous fads are frontal lobotomy. Sometimes good treatments were used faddishly and unnecessarily, like electroconvulsive therapy is a very good treatment, but in the past it was overused. Drugs have been overused. Psychotherapies have been overused. And then there are diagnostic fads, which include overdiagnosis of all kinds of conditions, including bipolar disorder, attention deficit disorder, post-traumatic stress disorder, major depressive disorder. So these are diagnostic fads which lead to overdiagnosis and overtreatment.
Right, but I mean, are some of those fads current or not? And I mean, what
the overdiagnosis? Yeah, the overdiagnosis fad is absolutely current, and people, clinicians, and their patients are believing in the absolute reality of these diagnoses, when in fact they are approximations. They are useful tools for communicating, but they're not diseases in the same way as you find in medicine. They are based on symptoms. We don't know the causes of many of the diseases, and many people use these diagnoses rather loosely. So, for example, anyone who's sad may be called depressed and receive antidepressants as a result. People who have mood swings may be called bipolar and be treated accordingly. So these are very much current problems for psychiatry.
Right. So I know that you were also worried about attempts of current theories to carry out biological reductionism. For example, you mentioned things like genome-wide association studies, neuroconnectivity, neurotransmitters, imaging studies. So what's the problem here with this sort of biological reductionism?
Well, in the past, we suffered from psychological reductionism when everything was due to a patient's childhood, and that's still a faddish idea which has a certain grip on many clinicians. The biological reductionism goes back to some successes that we had in the past. The introduction of antipsychotics for schizophrenia, the introduction of lithium for bipolar disorder, the development of useful antidepressants. These were all moves in the right direction. But the problem is, whenever something works, you want to give it to everybody. And that's sort of what happened in psychiatry. So the biological reductionism was an attempt by psychiatry to get back into the mainstream of modern medicine, which is been called biomedicine by some people because it's so biologically based. And I think we're right to explore these things, but a lot of premature conclusions have been drawn. So, for example, the genome, some people thought 20 years ago that now that we could read the genome, we'd be able to explain everything about mental illness. And that has turned out to be an enormous disappointment. because each gene that's been studied accounts for at most 1% of the variance. And in the major mental disorders, there may be hundreds or even thousands of genes involved, all interacting with each other. Now, the genome-wide association studies are a way of examining the entire genome, and you can score this by adding up the associations between specific genes and specific outcomes, and this then produces a polygenic risk score. But even these polygenic risk scores explain 5 to 10% of the variance, leaving most of it still unexplained, probably because the environment is not taken into consideration, and gene-environment interactions are crucial to understanding psychopathology. And I've written quite a bit about this, but the problem being that we don't understand enough about how these interactions work. Now, other things which have arisen in terms of biological reduction have been based on some of the new techniques in neuroscience, such as imaging. And these pictures are beautiful. People don't know the color is artificial, but they're wonderful pictures, and things seem to light up and they seem to be specific. But again, these findings tend to explain only a small percentage of the variance. Because it's such an expensive procedure, the studies are done on rather small samples. And even when one area lights up, if you look carefully, maybe 10 or 12 other areas are lighting up because the brain is highly interconnected between its regions. And there is some degree of localization, but there's also a tremendous spreading out of functions in different parts of the brain as they work with each other. So again, these are promising ideas, but people have claimed more for them than they deserve.
Right, but because we're mentioning here genome-wide association studies, what do you make of knowledge coming from disciplines like behavior genetics, particularly when it comes to the weight of genetics and environmental factors in the development of, in this case, mental illness?
Well, I'm a big fan of behavior genetics. It actually is a much stronger evidence for the role of genes in mental disorders than any of these other neuroscience measures. So in behavior genetics, we usually look at twins, and we look to see if identical twins, monozygotic twins, are more similar to each other than dizygotic fraternal twins. And from this, we can actually create scores, a percentage of heritable influence on an outcome. And we can also look at the environment, which can then be divided into an unshared environment, which is not related to growing up in the same family, or a shared environment, which is related to growing up in the same family. Most of the environmental effects, contrary to what people expected, have been unshared, and there are very few shared findings, and that goes against many theories. But again, because you're looking at gene-environment interactions, you can't look at these things separately. Now, what the behavior genetics literature shows, and you've had Robert Plomin on your program, he's a strong advocate of this, although I think he goes a little too far in terms of trying to explain everything genetically. But these heritability coefficients indicate that for almost any trait or any disorder, almost half, sometimes more than half, is heritable. But that doesn't mean that the genes are holding our lives on some kind of a string and controlling us. It only means that we have these tendencies which under certain environmental conditions can be positive and in which other environmental conditions can be negative. So mental disorders involve environmental factors which then amplify the effects of heritable factors, and these are gene-environment interactions. And unfortunately, it's hard to study these things, but there has been quite a bit of work, and I'm publishing a book next year called Nature and Nurture in Psychopathology and Personality. and and a lot of these studies are kind of impressive, and the best ones follow twins longitudinally over time, over the course of their development, and you start early on, and you see how they turn out as adults. So these are very expensive studies, but they become more common recently, and I think this could be the future of understanding the causes of mental disorders, which are still so mysterious for us.
Yes. And you also worry about the resulting dominance of medication in practice. I mean, due to these different sources of biological reductionism we've talked about. But I mean, to what extent do you think medication is a justified approach in psychiatry, and when do you think it's gone? I mean, it's too much already.
Well, for psychosis, it's indispensable, and it has a very specific effect on psychotic symptoms. And there are many mental disorders, particularly schizophrenia, where patients may need to be kept on these medications for a long time. And if they don't take them, we give them injections to make sure that they take them. And this doesn't cure the disease, but it controls it. And antipsychotics also control manic episodes, which often include psychotic symptoms. So in certain conditions, they're indispensable. However, antidepressants are being overprescribed. 12% of the population in North America are on antidepressants right now. And it's higher in women than men, so it's about 15% in women. Now, this is much higher than the prevalence of depression in the population in any given year. So why are so many people taking long-term antidepressants? Well, people sort of come to and often if one doesn't work, you try another one, or you add something else on. And many patients are taking antidepressants and antipsychotics, and sometimes mood stabilizers, and sometimes anti-anxiety drugs, and they're on 4 or 5 medications, and they're still not well. So I think we're over-prescribing antidepressants. The research shows that psychotherapy for depression is just as effective as medication, and in fact may have a more permanent effect long-term than the prescription of medication. But a lot of these prescriptions are being written by family doctors as well as psychiatrists, and it's very easy to write a prescription. It takes 5 minutes. But psychotherapy is not generally available in North America. You often have to pay for it. It's a situation is somewhat better in certain European countries, such as Germany and Scandinavia, where it's well insured. Another reason why psychotherapy is not used is people have the idea that it has to last for years to be effective, which is completely untrue. Most psychotherapies are brief, and even in chronic diseases like the one that I specialize in, borderline personality disorder, a short course of therapy can make a big difference. But somebody still has to pay for it, and the American insurance companies often don't. And in Canada, the insurance doesn't cover psychologists who do most of the psychotherapy. So there is an alternative to the overprescription of medication. And many forms of psychotherapy, which have been shown actually to be more or less equivalent in effectiveness, even if they have different names. The work of Bruce Rumpold is important there. And he brought in tremendous evidence showing that the general factors in psychotherapy are more important than the specific techniques. And psychotherapy works. We're not committed to supporting it and making it and creating access to psychotherapy. And that's one of the reasons we fall back on the prescription of antidepressants. And this is kind of unfortunate, because a lot of people are taking antidepressants, but if they get the right kind of psychotherapy, they might be able to get off of it. Some people may need both. So I was there at the beginning of the psychopharmacological revolution. I was an undergraduate student. I visited a mental hospital in which they had 4,000 patients. and they were just starting to use medication, and I saw what they were like before. So I was converted, to a positive attitude about medication from early time. As a resident training in psychiatry, I was the first person to prescribe lithium to an inpatient in our hospital, and with amazing, magical results. So if you use medication properly, it's wonderful. But if you insist that everybody has to be on medication and that every symptom has a medication, you're not going down a productive path.
Mm-hmm. But since you mentioned the importance of psychotherapy, what do you make of the recent proliferation of psychotherapies with different names, different acronyms? I mean, do you think that that's useful?
No, definitely not. It has to do with the ego of the people who create these things. It has to do with the fact that they have acronyms which are catchy. I mean, CBT, obviously, but others, EMDR and MBT and all these acronyms. And when you compare them head to head in research studies, the results are almost exactly the same. Even for the form of therapy that I've adopted for my borderline patients, which is dialectical behavior therapy, it's been shown that a less specific and more generalized form of psychotherapy can be just as effective for these patients, and that the real problem is getting them into what's wrong with them. So I think these thousands of acronym-based psychotherapies are a disaster, but people write books about their therapies, they sell them, people pay to go to seminars describing the latest thing. There's profits to be made. So it's, in a way, it's parallel to the interest of the drug companies in bringing in new medications, even though they're exactly the same as what we had before.
So since last time we talked about psychoanalysis, and today we talked already a little bit about behavior genetics, do you think that the common belief held by many clinical psychologists and psychiatrists that one of the most important risk factors for mental illness is trauma, specifically childhood trauma? I mean, do you think that's justified?
Yes and no. It's good that we're interested in this, and certainly it always has to be explored, but its effects have been exaggerated. That's another book I'm publishing in 2022 called Myths of Trauma. Because first of all, something like if you talk about things like PTSD, that also has a large heritable component, and it's related to how strongly people react to stressors, and we call that in personality psychology neuroticism. So people with high neuroticism are going to develop PTSD. Most people exposed to a traumatic event do not develop PTSD. Now then there's the question of what is the role in trauma in everything else: depression, anxiety, personality disorders. Some people have tried to redefine personality disorders and call them complex PTSD. And I think the problem is that it's a simple answer to something which is much more complicated. What do we mean by trauma? Are we talking about somebody who's had incest experience or severe childhood sexual abuse from somebody else? That's trauma. That's trauma. We're talking about somebody who's had a some life-threatening events. That's trauma. But the way trauma is being used these days is used to describe an unhappy childhood with all kinds of multiple adversities. Now we know that no single adversity is sufficient to produce a mental disorder, but multiple adversities over time, this was shown by Michael Rudder many years ago, multiple adversities over time are cumulative and have effects. But should we call every adversity a trauma and use a kind of a post-traumatic frame to understand it? Just as important as trauma is something called emotional neglect, where parents don't understand their children and brush them off when they have problems and don't help them to deal with their emotions when something is bothering them. That is actually much more prevalent among the patients that I see than well-defined trauma, although they do have more trauma than most other patients. So this is a complex issue, which again, the simplification to a single magic word like trauma is not helping us.
Right. So, I mean, another thing, what about the idea that mental disorders are mainly due to social and political problems? I mean, to what extent is society and politics responsible for mental problems?
Well, yes and no again. The role of social factors in mental disorders has been underestimated, and it's been left to the anthropologists and sociologists to study these things. It goes back to Emil Durkheim in the 19th century, who showed that alienation and social problems can affect the rates of suicide, for example. So, people who grow up in traditional societies, of which there are very few these days, but having lived in India for a couple of years when I was young, I had a chance to see what those societies were like, and they had very strong families, both direct, immediate family, extended families. They had communities. It sort of framed people in a way that it wasn't that they didn't have mental disorders, certain mental disorders which are more strongly biological, such as schizophrenia and bipolar disorder, are worldwide and don't have a radically different prevalence. I mean, there are things which have been shown, for example, famously in Britain, it was found that Jamaican immigrants had a higher rate of schizophrenia than people who had stayed in Jamaica and never moved to Britain. So and they explain this, which I think is credible, as having to do with some of the stresses of immigrations, particularly for certain people who are visibly different and may suffer from that. But that's not to say that schizophrenia is the main cause of its main cause is social or families, as we heard in R.D. Laing and some of the false prophets of the 1960s were claiming things like this. Again, we need a biopsychosocial model. This is a term developed by George Engel, who is a well-known psychiatrist in the States. And you have to think of it not as an addition of bio, psycho, and social, but an interactive model that includes all three in one model. And I've written something about this in my own area of personality disorders, where certain types of personality disorders seem to have become much more common in individualistic societies where there is less social support. And that goes with a lot of sociological literature. And whereas people in traditional societies, they do have other mental disorders, but they are also framed by a structure. I'll give you an example. There was a famous study in Taiwan, which in 1980, at which time Taiwan was still a very traditional society, and they could not find a single case of antisocial personality disorder, otherwise known as psychopathy, in a large survey in the cities and in rural areas. And this was a Confucian society where people are always looking at you, watching you, telling your parents if you misbehave. There was a lot of structure there which tended to suppress antisocial behavior. And it would be interesting to go back to Taiwan and see if you'd find the same thing today. Maybe it's changed.
Right. So earlier we talked a little bit about depression, but you also say that there are other conditions where there's an overdiagnosis, like, for example, bipolar disorder, ADHD, PTSD. So how do we know that there's an overdiagnosis of these conditions?
Well, we don't really, it's hard to say that we know it. I can only say the burden of proof lies on those who push these diagnoses too hard, and not on those who are skeptical. So let's take these things one by one.
Mhm.
Major depression is overdiagnosed, and the diagnosis is given to people who are sad and unhappy for any reason. But if they just fulfill 5 out of 9 criteria for more than 2 weeks, so it's a very low bar. And this has led to some claims that everyone has had depression, or at least half of us have had depression somewhere in our lifetime, and goes to explain those numbers I gave you about what a large percentage of people are taking antidepressants. Bipolar is a more serious, but antidepressants don't do much harm. They may help, they may not help, but they're not harmful drugs, and we don't know of any bad effects for people taking them for years. But in bipolar disorder, it's being diagnosed in all kinds of people who have mood swings for whatever reason. But some people with personality disorders have mood swings in which they blow up, they get angry, their mood is unstable. This goes on for several hours, then their mood changes, maybe it goes on for a full day, but they don't have what's called a hypomanic episode, which in the manual is defined as something which has to be at least continuously present for 4 days. And there are some people who have been pushing for bipolar and pushing so-called mood stabilizing medications, which can be helpful in bipolar, but are not helpful in conditions where you just have mood swings. So that's been a big problem. I think that one has peaked possibly. Perhaps in part because people have begun to observe the limitations of that approach. Now, ADHD is a big topic. I think it's being massively overdiagnosed. There are about 4 or 5 times as many people taking stimulants for a diagnosis of ADHD than there were 20 years ago. And patients are coming in and saying, I can't focus, I'm disorganized, give me Ritalin, give me a stimulant. And in the DSM, you cannot have ADHD unless you had it as a child. Now you can rewrite the history of your life and say, oh, I had it as a child, but nobody noticed. Or or my teachers didn't know what to do with me, but actually I never failed a grade and I had good marks. I mean, so you have to have ADHD during childhood. And a lot of the people who are being diagnosed in adulthood as having ADHD, which is where I have the problem mainly, did not have it as a child. Now, Terry Moffat is a famous psychologist who published data from the Junaidan long-term study. And what she found from New Zealand, which was a large birth cohort from New Zealand. I think you've had Belsky on the program.
Mm-hmm. Yes.
So your listeners will have heard about this. It's one of the most important studies ever done in psychiatry and psychology. And what they found was that most of the people who had symptoms that resembled ADHD and as an adult had never had them as a child. And the reason they knew that was they'd been following them since they were born. And they had evaluations of them every year throughout their childhood. And so Moffat proposed at this point that maybe there's another condition which looks like ADHD, which really arises maybe in adolescence and adulthood, but it's not the same thing as ADHD, and it may not respond to the same treatment. Now, to just add to our troubles, stimulants increase attention and focus in everybody. That's why we start the day with coffee.
Yes.
And if I take an amphetamine, I'm going to be better focused, even if I don't have ADHD. So this would be an example of what's been called cosmetic psychopharmacology, in which you're giving drugs to people to be better than normal. And so we see a demand, for example, university students who are overwhelmed by their work and their examinations and take these drugs in order to function. So when you see a change like this over a short period of time, and drugs are being prescribed at this enormous rate, and patients are demanding them from their doctors.
Mm-hmm.
So it's not that the ADHD is a myth, it's a real thing. Again, the question is, what are the boundaries? Now, this brings up a general problem in psychiatry, is that all our disorders listed in the manuals are based on symptoms, not on, and they do not have an ideological theory behind them, or only fragmentary ideological theories. So there are no biomarkers. In medicine, if you think something's wrong with somebody's liver, you can do all kinds of blood tests and scans and confirm your hypothesis. Brain scans don't have any clinical value in psychiatry because they're very nonspecific. And all these disorders are defined by their symptoms, which is why some people are proposing that we replace the categories of illness with broad dimensions similar to the 5-factor model of personality. This is called the high-top method, the hierarchical. It's a hierarchical way of describing psychopathology, but by means of scores. But again, these are only symptoms. They don't really explain the disorder. There are very few things in the manual which have a proper etiological explanation. I used to say that PTSD was the exception, but that's not the exception, because PTSD is not entirely due to trauma either. It's triggered by trauma, but it's actually a biopsychosocial. So this disorder, like all the others. So there are other disorders which have been overdiagnosed. Even my own subspecialty borderline personality disorder is now being overdiagnosed and I'm seeing people who don't have it, and people want me to treat these patients. Why is that? Because we now know that the disorder gets better with time, and it's treatable with specific forms of psychotherapy, which are in great demand but not readily available. So so diagnosis is something we need. It's something which allows us to communicate about patients, but it doesn't provide an understanding of the causes of disease, and we're 100 years away from that, at least 50 anyway. I won't live to see it.
So, but are there circumstances where perhaps we should medically treat people who experience certain, who have certain psychological experiences and behave in certain ways, even if that's the result of a human being normally responding to their circumstances, just because it causes them distress or something like that?
Yes, there are. That's a good point. There are people who come for therapy or even medication who don't really have a psychiatric diagnosis, but are unhappy for one reason or another. And nobody ever said life had to be happy. And so, but the question is, it's a matter of resources. I mean, do we want to spend? These patients like that can be managed fairly briefly, but we should be husbanding our resources for the sickest patients who need our services the most. Psychiatry has to work with clinical psychology, who's doing most of the psychotherapy, and social workers are doing some of it too. And psychiatrists are doing much less psychotherapy than they used to, and some don't do any at all and only prescribe medication and don't necessarily even refer patients for psychotherapy. So we need to to put our resources into the patients who need us the most. If somebody wants to have help with normal problems in life, a bad job, a difficult relationship, we can help them, but we should not spend the majority of our time on that kind of problem.
Mm-hmm. So you've already touched a little bit on this when you were talking about how we classify diseases. So is there a problem with relying on the DSM system of classification of mental disorders?
There's a big problem with it. I wrote a book on the DSM when it first came out, and then I wrote another book on Overdiagnosis a few years later. DSM manual, first of all, it's necessary, but I find with my students, they believe that it's the truth, and it isn't. I tell them, I say, look, this is a tool. It's a way of classifying patients. It's a way of talking about them. But it's not necessarily true that we have 200 categories, each one of which is similar to a medical disease or has a specific treatment. And this leads you down a really primrose path, because if you think that way, because you say my residents have said to me, this patient has the symptoms of depression. Why aren't you automatically prescribing an antidepressant for all of them? And the answer is because antidepressants work for some depressed patients and not for others. And we need to go beyond diagnosis to understand that. We need to be transdiagnostic and look at the much bigger picture. And of course, some of that has to do with life history, but it may have to do also with so-called comorbidities, which are run right through the DSM manual. Most patients, if they meet any criteria for any one diagnosis, will have 2 or 3 other ones. And they wanted to make the system better in 2013 when they brought out the 5th edition, but the data wasn't there. And so they had to stick more or less with what they had before, because we just don't know enough to have that kind of a manual. So, but the DSM manual, when the 3rd edition came out in 1980, it was a tremendous improvement, because it was at least based on some kind of a procedure where instead of taking one symptom and saying, oh, this is such a diagnosis, you had to count up your symptoms and have a certain combination of symptoms up to a certain threshold. And this was, I think, more useful at the time. But it didn't give us any insight into what we were treating or the effectiveness of our treatments in subpopulations. So I sort of take the DSM manual with a big grain of salt, but my colleagues who grew up, who are perhaps younger than me and have never known anything else, treat it as if it was the Bible.
Mm-hmm. So I would like to ask you a specific question about psychotherapy. So in the domain of psychotherapy and psychiatry, there's a lot of talk about the so-called therapeutic relationship. So what is this about, and does it play a role in clinical outcomes or not?
Absolutely, absolutely. So there's something called a therapeutic alliance, which can be measured with certain scoring sheets. It's better to ask the patient how good their alliance with the therapist, because the therapist always thinks things are going better than the patient thinks, by and large. And so these tend to predict the outcome of psychotherapy, although not brilliantly. I mean, we'll see a correlation coefficients of 0.3 or something like that. And if you square that, that's like 10% of the variance. So it's really not that clinically useful. So the characteristics of a good therapist, of course, are empathy, warm-heartedness, understanding life stories. A lot of this was described by a famous psychologist 60 years ago, Carl Rogers, where when he talked about the relationship being maybe sufficient for the patient to get better on their own, and he wasn't much into skill training of skills. I think with CBT and its other derivatives like MB, like dialectical behavior therapy, we're much more now into skills and techniques and getting into a teaching mode. But in order to get your message across, and in order to have, and just like a teacher in a classroom, if you don't have a good relationship to the people that you're working with, they're not going to listen to you. So this therapeutic relationship is sort of, could be described as necessary but not sufficient for a good outcome. If you don't have it, you're not going to get anywhere. And sometimes it's because you don't understand people, and sometimes it's because the patient doesn't form an alliance with anybody and is sort of deeply paranoid, doesn't trust anyone, and really maybe is not a good candidate for psychotherapy. And we do see people like that. But this therapeutic relationship is a sort of a sine qua non.
Mm-hmm. So just one last topic. Do you think that psychiatry is well equipped nowadays to predict and prevent suicide?
Yes, well, this is another topic on which I've written a book and a couple of articles I updated. I'm publishing an update article on this literature this month, actually. And this interested me because I felt that one of the big justifications for training oneself as a psychiatrist was to deal with suicidal patients. And this is the patients I've always been interested in. And some of them will commit suicide, but most of them won't. And so what should we draw from this? So is there such a thing as suicide prevention? And I reviewed the literature quite thoroughly. And a lot of people talk about it, but they really come to rather misleading conclusions. If you have patients who are thinking about suicide, which is very common in depressed people, and you treat them successfully, of course their suicidal ideas are going to go away. But they wouldn't have committed suicide. They were just thinking that way because they were in such pain, they were looking for a way out to escape. And suicidal ideations probably occur to half of us at some point in our lives, according to epidemiological data. Now, what about suicide attempts? About 5% of people will make some kind of suicide attempt or gesture in their lifetime, often by overdose of pills. Some people will include self-harm in that, like people, we see this a lot with young people, where there's been a kind of a social epidemic of cutting yourself to relieve mental pain. Oh, that's not really suicidal. But there are a number of people who have made some kind of suicidal behavior. And again, if you intervene with these patients and your treatment is successful, it goes away because they feel better, they have something to live for. But who are the people who commit suicide? They don't come to us that more often. Most people who actually die by suicide have not seen a professional, or if they have, it was only for a checkup and they didn't mention they were thinking of suicide. And most people who commit suicide kill themselves on the first attempt and use methods which are likely to be fatal. And they're much more likely to be men than women. Women have a higher rate of suicide attempts. Men have a higher rate of what's sometimes been called completed suicides or fatal suicides. And these men will hang themselves, or they will shoot themselves. And they'll do it on the first try. And these suicides are not readily preventable. So our clinical work in psychiatry on suicidal patients focuses on those who have suicidal ideas or suicidal behaviors, but not on those who are most likely to commit suicide. That having been said, every psychiatrist who treats sick people is going to have the experience of having a few of them commit suicide, and you have to accept that. as part of the burden that we carry as professionals. What might prevent suicide is not us, but other things. So, for example, in Britain, when they replaced coal gas in stoves, which was where famous people have put their heads in stoves, the poet Sylvia Plath, and died from it. When they changed the stove so the gas in it was no longer could kill you, suicide rates went down. It's a bit controversial, but there's some evidence of putting barriers on bridges so people can't jump off of them. They have a certain effect in preventing suicide. By and large, I would say we're not so good at preventing suicide, but we're pretty good at helping people who don't really want to die but have mixed feelings about it, and who need help with their intense and depressed emotions. And that's where we can make a difference. So I find suicide prevention, some of the claims that are made for it, very misleading, because they're about the successful treatment of suicide attempters and not about catching people who are most likely to commit suicide, but who actually don't come to psychiatry. So this is a very complicated question, and not everyone agrees with me, because some people have devoted their whole life to suicide prevention. But as you can gather from what I've said about all the other questions you've asked me, I'm a skeptic, and I value being a skeptic, and I try not to go on bandwagons. And I think my profession has brought a lot of good to the world, and I feel my 50-year now career, I've helped a lot of people. That doesn't mean that I know how to prevent people from killing themselves. I don't.
Okay, so Dr. Paris, before we go, would you like to tell people a little bit more about the books you're going to be publishing in the near future?
Yes, well, I have two coming out. One of them is called Personality and Nature and Nurture in Psychopathology and Personality. That'll be out with Routledge next year. And a second one is called Myths of Trauma with Oxford University Press, also for next year. I published several books last year. If anyone's interested in borderline personality disorder, I published a second edition of my book on the treatment of borderline personality disorder with Guilford Press. I also published with American Psychiatric Publishing a book on nature and nurture in mental disorders, more oriented to the DSM manual. And so you might say I'm addicted to writing, but I enjoy it. And sometimes people come up to me and say they like my book, and that makes it all worthwhile.
Very well. So I will be leaving some links to the books in the description box of the interview. And Dr. Paris, it's been a real pleasure, as always, to talk to you. Thank you so much for taking the time to come on the show.
Thank you for giving me a second chance to talk about my other areas of interest. And thank you for being such a good interviewer.
Hi guys, thank you for watching this interview until the end. I would like to ask you to please consider supporting the show. You will have links in the description box to Patreon and PayPal. Any amount, even just $1 per month, would already be a great help. Otherwise, and if you like what I'm doing, please share the interview, leave a like and hit the subscription button. This show is brought to you by Enlights Learning and Development Done Differently. Check their website at enlights.com. I would also like to give a huge thank you to my main patrons and PayPal supporters, Karen Litska, Anne Blanchett, Parerga Larson, Lau Guerrero, Francis Ford, and Frederick Sunda, Ricardo Vladimiro, Craig Healy, Adam Kessel, Olaf Alex, Jonathan Wiesel, Jacob Klinkby, Matthew Whittingbird, Arno Wolf, Tim Hollis, Henry Kalenia, John Connors, Paulinda Barron, Philip Force Connolly, Jerry Mueller, Herbert Gintis, Rutger Voss, Bo Weingard, Rebecca Newberger Goldstein, Dan Demetrio, Robert Windiger, Rui Inácio, Arthur Coe, Zup, Marco Neves, Colin Holbrook, Susan Pinker, Bernardo Seixas, Pablo Santurbano, Simon Columbus, Jorge Espinha, Phil Kavanagh, Corey Clark, Mark Blythe, Roberto Inguanzo, Mikkel Stormir, Eric Neumann, Samuel Andreev, Tiago Nunes, Bernard Hughney, Alexander Dunbauer, Omari Hickson, Fergal Cusson, Ivan Bodrenko, Hal Herzog, Don Ross, Jonathan Librand, Oslam Bullitt, Nathan Nguyen, Stanton T, Samuel Correa, Eric Hines, Mark Smith, J.W. João Weira, Tom Hummel, David Sloan Wilson, Yacila das Araújo, Eden Solon, Romain Roach, Dmitry Grigoriev, Diego Londonho Correa, Tom Roth, Yannick Punter, Adana Rusmani, Charlotte Bliss, Nicole Barbaro, Adam Hunt, Pavel Ostazewski, Nelek Bach, Catherine and Patrick Tobin, Al Ortiz, Guy Madison, Gary G. Hellman, João Linhares, Lida Cosmidi, Saima Afzal, Adrian Yegi, Nick Golden, Paulo Tolentino, João Barbosa, Jules Price, Edward Hall, Edin Bronner. My producers is our web, Jim Frank, Lucas Taffini, Akian Gilligan, Sérgio Codrian, Luís Caetano, Tom Vanegdam, Curtis Dixon, João Linhares, Benedict Mueller, Vega Guidi, Sardas France, and Thomas Trumbull. And my executive producers, Michel Rugieski, Rosie, James Pratt, Matthew Lavender, Sergio Codriano, and Jason Party. Thank you for all.